out. So we have some questions already, which one of the network members will be reading out now. In person of Ayojo. So we'll be taking we'll be reading out some of the questions, and while we answers will be given to some of these questions. So thank you so much. So over to you, Ayo.
And thank you, Abayomi. Can everyone hear me well, please? Can everyone hear me well? Okay.
Yes, loud and clear.
So,
yes, we can.
Okay. So there is a question here from Efosa, and the question is, given the concept of humanitarianism, the core being humanity and humaneness, do you think humanitarian medicine is strictly NGO and private sector driven, devoid of governments directly or indirectly? Put differently, do you think private and individuals should be involved singly humanitarian medicine? So I think we should start with that one. Our speakers, Professor Te, Professor Bola, and then Mr. Adeniyi and Reverend George. Up to you. Okay.
Sorry, I think is it possible for us to take like 2-3 questions together in order just for us to cover some questions? Okay. I'm just yeah.
Okay, for the second question is from Suto, and is it ironic that the leading imperialist questions, is it ironic that the leading imperialist countries are also leading humanitarianism? Does it speak to the limited conceptualization of humanitarianism in ways that it excludes, for instance, African support for crisis in the West? How do we overcome the coloniality of humanitarian narratives such that it does not sound like the West's benevolence to troubled Third World? And then there's another question from Mr. Taye Akinsomi. So you mentioned the Opozengo of Benjamin in correlation with DRC Congo, one of the most richest in mineral resources in Africa, yet the poorest. So what is the usefulness of humanitarian medicine, if not exploitation? Please explain.
I think that message is for Bertrand.
Okay, well, I have actually answered in the chat to some of these questions. I think the point I was trying to make is that it's difficult to define who is a humanitarian, because it's a self-definition. So a lot of actors could describe themselves as humanitarians. We've seen, for example, the military claiming to do things in the name of humanity and acting in a humanitarian fashion. I would say that since the 1990s, after the Rwanda evaluation, with the disastrous response to the mass displacement in Goma, there has been an effort to create a set of norms and standards, and if you want a quality threshold. Now, one good question is, of course, is this not possibly a trick by the largest humanitarian organizations to create a club of which they are policing the borders? And in other words, are they just rising the cost of becoming a humanitarian organization? But in reality, so many humanitarians, as we've heard today, actually come from a variety of backgrounds. There is a very easy circulation between the WHO, Ministry of Health, and humanitarian organizations. The same personnel, the same people can have have careers across these sectors. So I think it's more complicated than sociologically. It's a difficult thing to define. There is no ontological definition of what a humanitarian is. So that's one point. So the issue of is it surprising or ironic that many very large international non-governmental organizations started in the north or the west, whatever, or in the north? I don't think it is, because it's a reflection of two things. I would say humanitarianism is conditioned on two or three major technological changes in the 20th century. The ability to transfer money, that is, you can raise money in a part of the world and ship it out to the other part of the world that happens in the 1860s. The ability to actually send medical equipment and medical resources, and the ability to report back on it through journalism. Most of these technologies were developed in northern context, and you find them in the north. So I think that's one reason it began there, but that's also a reason why it cannot remain there. You know, it became, people in Africa can transfer money very effectively with their mobile phones. They can do it. There's a range of technologies that have been taking place. Now, the ability of shipping out a humanitarian medical team is an expensive thing. It's very expensive to send a team from one country to the next, because you need to get through a lot of regulatory frameworks and travels. But nevertheless, you find that there are some West African NGOs that were involved in Haiti in 2010. So it's, you know, it's not true anymore that it is a north-south relationship. And more importantly, those big NGOs like Médecins Sans Frontières now employs 26,000 people. Now, most of these people are not from the north, like 80% are not from the north. So the question then asked, and these are members of an organization. So the question is, of course, at what stage do you decide an organization is no longer of a particular nation? I think we've reached that stage about 10 years ago.
Okay, thank you, Professor Tay. There is another question here, and could you please shed some light on the role of the WHO in humanitarian medicine? That's from Professor Noah Atta. Then there's another question from Peter Hacker. What led to the development of vaccine and drug production units in the medical compound? So I think that's to Professor Bola and Mr. Olusoji Adeniyi.
Okay, thanks, Ayo. The role of, actually I've answered this, but I'll just summarize the role of WHO. And one thing I think we all need to know is that a single organization alone cannot respond to a humanitarian crisis, because during a humanitarian crisis, there are various needs. There's the need for health, there's the need for shelter, there's the need for education, there's the need for water, and all of these needs have to be met by different organizations with different mandates. So for WHO is the lead agency for the health cluster. And the health cluster is made up of the different organizations, whether they're private, whether they're NGOs, whether they're government or international NGOs. They all come together under whatever cluster it is you are supporting. So WHO heads the health cluster, works in the coordination, works in providing the standards, working together with the other teams to identify the priorities, you know, and also working on the plan. Then apart from that, WHO works to really ensure that in spite of the humanitarian crisis, essential health services are being provided. And what do I mean by essential health services? Pregnant women are being attended to, children are being immunized, you know, illnesses are being taken care of. So that's part of what WHO does in the health cluster. On the second question, do I remember what the second question is now?
So, what led to the default of?
Now that it's a very long story, but I'll just summarize it as one: a government came in for which it wasn't a priority, and you know, I remember I mentioned the need for critical funding to ensure that these systems work and evolve. So it wasn't a priority. The funds were not available to continue the production. Another government came back and wanted to resuscitate it, but it was just done as what was a contract. So the necessary assessment, evaluations, and planning wasn't done, and it became an elephant project. And many years passed after that. So that's what happened.
Okay, thank you. Thank you very much. And there's a question for Mrs. Daly George. And there's a question here that says, I would like to know what role Little Saints play in terms of ensuring the safety of babies given out to their foster parents. Does Little Saints conduct routine visits to homes where their children had been adopted internationally? In an event where some form of unpleasant situations are found, what steps does Little take in such situation? Then there's another question. I have a gender question. Growing up in Nigeria, I remember there were frequent cases of female babies abandoned or thrown away, and some orphanages were filled with more female children than male. So has this changed, or can you give a rough ratio of female/male abandoned babies and of children in your orphanage home?
The first question, actually, orphanages are not permitted by the government to do a follow-up on adopters. And I think it's because they want to protect the children. They want to protect the privacy of the families. Because as you know, in Nigeria as a whole, childlessness or not having a child in a family is still a stigma. And a lot of people are still doing adoption secretly and privately. So it's important that the children are not exposed as being adopted in many, I would say in at least 80% of the cases. Maybe just 20% are open adoptions. So in Nigeria, we're still getting used to adoption. You know, we're still trying to sensitize the public about the benefits of adoption and how important it is for children who don't have parents to be adopted. So the ministry fully are in charge of monitoring adoption in Lagos State and in Nigeria. They are in charge. And I can say to you that they are very proactive and efficient. I mean, recently we had a case of a child that was going through a lot of challenges in the home. And within 24 hours, a visit was made to that family and something was done about it. So they do the monitoring of these families. And the families are mandated by the courts because adoption is actually finalized in the courts. It's finalized in the magistrate courts. So they are mandated to report occasionally to the ministry concerning the progress of these children. And they are not allowed to take the children out of the country without the permission of the ministry. So I can say to you that the Ministry of Youth and Social Development are fully on top of this monitoring. And I think that they are doing their best so far. We've not had cases that were really, really out of hand. And then what was the other question?
The other question is, I have a gender question, growing up in Nigeria.
Okay, yes,
okay.
Yes. If I want to use Little Saints as an example, we have more female than we have boys. You know, so if that will answer your question, yes, of course, more female children are being abandoned. But on the whole, the children that are mostly abandoned are actually children that are sick, all right, children that are physically or mentally challenged. Those are the children that are mostly abandoned in Nigeria. So more girls are being abandoned than boys.
Okay, thank you very much.
All right.
And there is a question here for Mr. Olusoji Adeniyi. The Public Health Acts of Eastern and Western and Northern Nigeria of 1950s under the colonial government influences provided that each local government area had a medical officer of it to ensure as much preventative health services as possible. And where one could not be appointed, the medical officer in charge of the general hospital looking after that area must act as a medical officer of health. But we created our present states out of this regional government, but failed to provide for this humanitarian fees of the organized health systems in these states, nor even to pay, support, and retain those so appointed. So what should we do about this as a people? So
okay, I think that we should understand that we are evolving. If we move from a regional structure to a state-based structure, how many regions did we have? The northern region, the eastern region, Midwest, Southwest. That was what we had, you know, until we moved to the states. 19 states, then 27, then 36 plus 1 that we have, and people are still agitating. So no matter how we make effort, there will always be agitation, because even within a local government, because of the multi-ethnic, multi-cultural tendency that we have, because of excess, you know, influence placed on religion, people will always want to make demands. The key thing is not whether there is a medical officer of health in charge of humanitarian action, but whether there is a system in place in the states For instance, I was privy to the establishment of more than 21 state emergency management agencies. And each of the state emergency management agencies has a mandate to coordinate humanitarian response, irrespective of where it was happening. So I think to a large extent, that covers the need that, was the fears of the colonial masters as at that time. Those kind of needs are now subsumed under a more holistic approach in the state's emergency management agencies. What we just need to do now is to encourage the governors to see the state emergency management agencies not as a response agency, but an holistic emergency management agency, which is, the advocacy that we all need to make. Thank you.
Oh,
Thank you so much.
Okay.
So can Tolu give some read out some questions too? If you have some questions with you, Tolu, if you are there, please kindly read out some questions.
Okay. Thank you, Abayomi. I think on my own, I have two questions. One for Professor Olayinka. So I wanted to know about the indigenous public health practices, in particular in Yoruba land, before the onset of colonialism. What were the mode of public health practices? And to Professor Bertrand, I wanted him to share more light on the impact of humanitarianism services in maternal and infant health.
Okay, thank you. I actually answered the question in the chat, and I said, yes, there were quite a number of practices which had been indigenous in the past. Some of them are still in existence. Some of them have been useful. And I mentioned things like herbs, things like the handing down of some secrets from one generation to the other, the use of traditional birth attendants, and some of these are still in practice, like I mentioned. Some have evolved, some have been discarded, like we all know about the genital mutilation. So these things have been there. They've been in existence before colonization, but there has been a lot of involvement. There has been a lot of refining of some of them, and also some which were not helpful or could be dangerous have also been discarded. And the other question, let me just answer that, because someone particularly mentioned my name, was on whether there was a need for another agency to focus on the biology of infectious diseases and infectious agents. And I mentioned that we already have an institute which has that mandate. That's the Nigerian Medical Research Institute, the Nigerian Institute of Medical Research, NIMA, in Yaba. That is actually the mandate, and it's not, which is the scope out of NCDC. Over.
So I guess, so the point, I mean, historically, where does humanitarian medicine fit in relation to maternal health care? And I think first point I'd like to make two small points. One, the first one is that international humanitarian aid is often symbolic rather than, it's not the bulk of the delivery of aid. Most of it comes from the countries themselves. So you have to put those things in perspective. However, the emphasis on maternal health and child health is really old in humanitarian practices. It's partially linked to religious movements. So, the orphanage, as we've heard, orphanages, childcare have been traditional activities of religious organizations for a very long time. So there is an inheritance from that perspective. Organizations, secular organizations like Save the Children, emerge very early on and are very powerful in conveying the the nature, the brutality of a particular situation, systemic or war or what have you, and the child, in a sense, has always been the ideal humanitarian subject, because the child is by nature innocent. And I think that's a very important aspect. Now, the emphasis on maternal care, and in the 1920s and 1930s in Africa in particular, is directly linked to the fear that Africa is experiencing a catastrophic demographic crisis, a byproduct of colonialism, undoubtedly, a byproduct of globalization, of increased exposure to diseases that have spread across Africa because of colonialism to a large extent. And I think that emphasis, therefore, on maternal care and childcare becomes part of a lot of inquiries, and the Save the Children conference on 1930, which brings together all the so-called experts of the time, is really centered on this issue of maternal health care, and especially the death rate of babies and infants. And I think there's a lot of emphasis in that period, in the 1930s, on trying to improve on those particular indicators. It's interesting, of course, because survival of the child and survival of the mother are very easy health indicators. Okay, they're fairly straightforward to measure, and I think in many ways, the role of humanitarian aid went for the easy fruit, easy targets, and that's an easy health indicator to measure, not necessarily to address, but to measure.
Thank you very much for the brilliant responses. And I have two more questions here on the chat that I'd like to read out. But before then, I also have another question for Professor Bertrand. And I was thinking, if time will not permit, I'd like to have a conversation with you maybe after the seminar. So I was wondering, is it possible to situate the missionaries when we talk about humanitarian services in times of maternal and child death? First, we have colonialism, colonial masters came. Then after that, we have the medical missionaries. These two set of people were working towards engendering maternal health. Then who were the humanitarian to say? Is it possible to situate the medical missionaries in this respect? Then the other two questions that I have here is from Professor Asuzi. I hope I pronounced that correctly. First, he asked, could humanitarian medicine be better termed organized medical charity in crises and emergencies? And the other question he asked, that if the idea of humanitarian medicine is saying that there is something wrong with medicine itself, or a need to find another term for what we're talking about, is this not obvious to us all? Over to you, Professor Bertrand.
Okay, so complicated. So a small point, but I think important, that missionaries and colonialists are not the same. The missionaries and colonialists often inhabited the same space. Sometimes they followed each other. Sometimes the missionaries came first. Sometimes the military came first. But if you look at the diffusion of religious groups, they don't follow imperial boundaries. So for example, the White Fathers, who organized the Catholic missionary medicine earliest in the Catholic Church, they're not stuck to the French Empire. They actually reached out for places that later became part of the German or the British Empire. So they have an imperialism of a different kind. That's what I'm saying. They're not quite the same. The second point that you raise is of course in the contemporary world. So since the 1980s onwards, humanitarian medicine has been multifarious. it's emergency medicine in a multitude of emergencies. It's often, and I think Mr. Adini has shown this very well. It's a wide range of collaborative efforts between a wide range of actors, where I think humanitarians have played an important role, and against, if you want, established medical establishments, has been in the last 30, 40 years in contesting the nature of the medical market, and actually contesting the cost of drugs, the dissemination of drugs, and pleading for additional research in so-called neglected diseases, which essentially are tropical, most of them are tropical diseases that had been neglected by the big pharmaceutical industry, and contesting the cost of the compounds emerging from big pharma. Now, in my personal work, I've worked on hepatitis C, okay, which is a very small, well, it's an important disease, but it's not a very big major emergency. It kills people very slowly. But hepatitis C was the drug that cures hepatitis C was retailing at something like $120,000, okay, for 12 weeks of treatment, about 10 years ago. And now you can buy it if you're in India, you can buy it for $80 or less, $30, I believe, in some states. So I'm not saying it's only humanitarians that have achieved this. The Indian state has achieved this. The humanitarians have achieved this. There's coalitions of groups that have been contesting the economic basis on which a lot of especially drug retailing is taking place, and also trying to bring alternative technologies, because I think one of the key problems of modern medicine is the constant drift towards more expensive solutions and complex solution, and that's very visible, for example, in relation to oncology or surgery, and of course the problem is that these are not necessarily widely available. So humanitarians have often favored an ethos of looking for affordable solutions that can have similar or equal, if not superior, health outcomes. And I think it's a convoluted answer to a complex question, but thank you very much for your question.
Yes, thank you. We have a few minutes left, but before we actually close for the day, still have some questions here. And before Oluwashola Daniel will be asking some questions, there is a question from Professor Kenneth here. Says that, may I find out if there are efforts to mainstream aspect of humanitarian and emergency medicine in history curriculum at the university in Nigeria? And is it already in the curriculum? Do I actually say that we will allow my prof to ask his question, because I can see his hand up. So can Daniel read out his questions to maybe if Professor Kenneth can still ask some questions, or maybe any contribution, I don't know. So please, Daniel, quickly, can you just read out some questions before we call it a day? Thank you.
Okay. Thank you for letting me do that. The question I have here, the first one from my side has not been answered. How can we describe the existing human resource in public health response in Africa and Nigeria in particular? And I think the last one will be directed at the organizers. Please, could you share the recording of this seminar? Yeah, I think that one should be on YouTube, I think. Yeah, I think that's
okay. Let me take the human resources, the health, human resources. I think that we have a wonderful opportunity. I mean, there's a lot of attrition as we speak. A lot of medical health professionals are attracted to the developed countries to practice based on several factors. One of it, which is the quality of pay, the environment of practice, the availability of, appropriate technology and equipment to support their work. Everyone wants to work in an environment that is conducive for efficiency and effectiveness in their professional life. But I see it positively in my own personal space, because I believe that whether you are talking about, experienced consultants or medical assistants or nursing officers, all these can actually be turned on its head, and we can become a mass production centers for all these technology-based skills, whether they're in the medical field or in the engineering field or any kind of fields at all, that can produce the number of required professionals that the world needs. Because eventually these people will give back to their country at some point or the other, either when they're tired of being abroad, or I was abroad for several years, but at some point I decided to return home to support the country. While I was abroad, I was still remitting home some substantive amount of my income. So I do not see it negatively the way people see it. They call it the Japa syndrome, and every young one just sees it as the next big thing to happen. And so the people in the industry are also seeing it as depletion of the workforce. And then, of course, there are lots of gaps in the industry. But we have also placed certain restrictions on our faculties of medicine, on our medical colleges, on our research institutes, that prevents the number of people that we need to produce, to actually be produced on an annual basis. We have strikes, we have all kinds of things that restrict it. We have our laboratories that need to be upgraded. So if the country would turn its eyes on those facilities, those institutions, those universities, and set up chairs and faculties and systems that will produce what the world needs, they will have sufficient for the country. We have 200 million people that would need to be attended to. So there will always be, those who would stay, and those who would want to go can also go on even an arrangement that is sponsored by the government, that you would go, you would, be able to pay for your residency and whatever it is that you want to do there using a loan facility from the government, and then you will pay back. And then, of course, government can also make incomes and revenue from such export of intellectual capacities. Thank you.
I think you're right. So straightforward. And I think one of the interesting points about humanitarian medicine in the last 30, 40 years, if you want, is that we moved away from just disaster response or the most acute form of response. And now humanitarian medical practitioners are involved in things like how do you deal with diabetes, with heart disease, with cancer? Things that are becoming more and more common as basically Africans start eating not so well anymore, and the result is so diet issues, lifestyle issues are becoming more central to the concerns, and that means the boundaries between this emergency medical world of humanitarianism of the past and what we just call public health is really, really thin now. And I'm seeing it in many places. Humanitarians are asking themselves, well, we really need to engage with those issues that are much broader, much more social issues than just responding to a flood or a famine or an earthquake or a war.
All right. Thank you so much. We appreciate you. I think we are 6 minutes behind the schedule time. So we want to say apology for for using that 6 minutes. So we appreciate you for coming. It's been a wonderful session, and we really, really appreciate you on the seminar on the value of history of humanitarian medicine and public health emergency response in Africa. Want to appreciate our speakers, Bertrand Tiet, Paula Olayinka, Dele George, and Soji Adeniyi for coming to enlighten us and open our heart and our mind to things we've not even take cognizance of before. So really appreciate you, and thank you for everyone on the meeting tonight. We also appreciate you. Out of your tight schedules, you still find time to attend. So really appreciate you. So we'll be having this seminar time to time, and we really love you join and partake. We want to learn more from you. We want to learn more from you. So to develop Africa. So, and I really want you here. So on behalf of Nigerian Health Historians Network, we are saying a very big thank you to you. Zoom is still open for networking. If you want to network, want to meet people, so kindly do that. Please, you still have some minutes to do that, but the meeting is over. But if you still want to be on the Zoom to meet your friends or to network with people, so kindly go ahead and do so. So what we say a very big thank you to everyone for coming. Thank you so much.
Thank you very much. Goodbye.
Thank you. Enjoy the rest of your evening.
Thank you.
Thank you. Thank you.
Thank you to the speakers. Thank you for everyone. Thank you.
Yeah.